All right. Thank you, David. Yes, perhaps I have the short straw for the BAV question. Maybe I have a fighting chance. So why, in general, flow imaging? Well, I guess one theoretical answer to that question would be that for some types of vascular disease, flow is the cause rather than the consequence of the disease process. So with this rough analogy here, the high flow in the river, if left unchecked for many years, may carve out the Grand Canyon, the wall problem. Let's see. Off we go. All right, so that's perhaps a theoretical answer. The practical clinical answer, of course, is a lot more challenging to come by and really depends on the disease process that we're talking about, as David kind of outlined. So what I'll do here is sort of not answer the scenarios that David put forth with the beginning part, just to get a feel for how flow imaging can be useful, reviewing 3 current clinical examples of flow imaging, and then to sort of move towards those questions a bit more with a couple techniques in the research space that have shown promise. For the sake of time, I'll just focus on the category of high flow is bad. All right, so to my first imperfect example. Imperfect, of course, because this is not vascular imaging, but rather cardiac imaging. I think it's useful to go through just because it provides a blueprint of the boxes you'd like to check for a compelling clinical application of flow imaging. So, mitral regurgitation, which would you like to intervene on early on in the disease when you have normal ventricular size and function, or the bottom image where you've had vessel wall remodeling, looks pretty dilated, and you're on that slippery slope to heart failure. Of course, it's appealing to think that intervening early would be helpful, and I think this is sort of a nice exercise to kind of walk through the various components of a good clinical application for flow imaging. So here we have a defined cohort. This would be asymptomatic patients with mitral regurgitation as defined by echocardiography. Echocardiography is notoriously mediocre for quantifying mitral regurgitation. MRI flow imaging steps onto the scene with its better quantitative abilities, specific variables, specific cutoffs, and if these cutoffs are surpassed, a clear message for how to manage that patient, which would be, all other things being equal, to strongly consider repairing the mitral valve. Okay, to my second imperfect clinical example of flow imaging. So at least we're in the right disease process here, carotid disease, atherosclerosis, but of course we have the wrong modality here. We're looking at CT. So looking at these 2 CT images, conventionally you'd look at them and decide there's a significant stenosis in the top and the LAD, the bottom, and the right coronary, and these should go to cath for potential intervention. But we all know that not all stenoses cause ischemia, and we're all aware that FFR is the next move to decide which lesion should be intervened upon. And importantly, based on a lot of recent research, this FFR analysis, which can be done non-invasively based on CT data, has passed an important threshold. It's now reimbursed by Medicare in the United States. And as a quick aside, maybe MRI can get back in this game. We heard earlier that perfusion imaging with MRI performs with similar diagnostic performance to FFR. So why is it compelling? Well, if you go back to our 2 cases, which conventionally would have to go to the cath lab, when you do the non-invasive analysis, in the first case, the FFR drop to 0.62 is significant. That patient should indeed go to the cath lab. Second case, though, a little bit surprising. It looks pretty bad on the CTA, but then when you look at the FFR analysis, not too bad, and you've saved this patient an invasive procedure. Okay, to my third imperfect example, so right disease process, atherosclerosis of carotids, wrong modality, ultrasound, and I walk very cautiously into this territory knowing that this is a very compelling topic for wall imaging, but just a passing observation as an observer to this type of imaging. I don't do it clinically, but little has changed practically in how carotid disease has been managed over the last 20 years or so. Carotid ultrasound really is still the first line of defense, and the exact same approach with the same table that I used 15 years ago as a resident is still on the wall in the reading room and used. And generally what you do is you look at the degree of plaque and narrowing. In this case, it's a little bit more than 50%. You look at the downstream acceleration, here 141 centimeters per second. You turn to that table on the wall, and the plaque offers something, but the fine-tuning in terms of how you grade the degree of stenosis usually comes from the velocity information, in this case placing it in the category of 50 to 69% stenosis. So just a reminder to everyone that flow imaging is used all the time clinically with ultrasound. It's fast, it's cheap, it's readily available, and it's a good, though obviously imperfect, means of categorizing vascular disease. Okay, so let's tack now to the research side of this, where flow may be the driver of vascular disease. And just a quick entry point here, let's talk about wall shear stress. This is the frictional force that flowing blood exerts on the vessel wall. As a quick reminder, healthy vessels should have an intermediate level of shear stress. Things can go wrong at both ends of the spectrum. So if you have low wall shear stress, that leads to the generation of atherosclerosis. On the other end of the spectrum, if you have high wall shear stress, this can lead to vessel wall damage and remodeling. A bit more about some of the pathways that are at play. So usually downstream of a plaque, you see low wall shear stress, and you can kind of look through that list. LDL accumulation, smooth muscle cell proliferation, monocyte recruitment, all these things that generate large atherosclerotic plaques. Upstream of a plaque is where you get your high wall shear stress, as we were talking about before. Different set of things are put into play here that degrade the media with matrix breakdown and a variety of other mechanisms. And just to end here, I wanted to focus on this category of high flow problems, because I think those are the applications that have come closer to clinical practice with flow imaging. So the first one is BAV aortopathy. I think it's a very good clinical question. 1 to 2% of the population has this problem. The majority of these patients eventually develop aneurysms, and there's been controversy over the last couple of years in how to manage these patients, when to go for elective surgical repair. This, by the way, is from the early days of this field with a computer simulation of the off-center flow that you see with the bicuspid aortic valve, putting a lot of stress on the outer convexity of the aorta. After this, many groups put together pretty sizable cohorts demonstrating this exact type of flow pattern. And a high point in the field was, based on all of our studies, we were officially considered a contributor to BAV aortopathy, flow was, in a New England Journal article in 2014. But 5 years later, the somewhat disappointing news is we still don't have a clear clinical application. I was thinking about why this was on the plane ride over, and the pessimistic answer is maybe the application isn't there, but I do think there's hope and some optimism here, and that I'm not sure we've gotten it quite right. So some excuses I came up with are, it turns out that during the period we were all studying this with lots of intensity, the disease was probably overtreated. There's AHA guidelines from 2010 that were very aggressive, so a lot of the interesting patients were likely removed from the cohorts that we studied. These would be the growers that would give us positive results. It's probably a narrow window when this type of analysis is most relevant, probably patients around their 20s. And a lot of the cohort studies are a little heterogeneous with respect to age, and then sometimes with respect to stenosis and insufficiency as well, so heterogeneous cohorts. Aortas grow slowly, so it's unlikely you're going to capture an interesting result in a grant period or grant cycle. And then lastly, in this field, there have been tons of candidate variables that have been discussed, but few longitudinal studies that have given these variables meaning. And I think switching that ratio with more longitudinal studies and then kind of focusing on a couple key variables would be the way forward. Okay, to the second of the promising applications, I picked type B dissection. So this is a good clinical story, and that many patients with type B dissection do just fine with medical therapy. However, there's a subset of about a quarter to maybe a third that have progressive disease, and there's pretty high mortality in this group. So this is a case that Nick Burris gave me. Nick's going to speak more extensively on this tomorrow, where when you look at the first image, you shrug, type B dissection, relatively small aorta, nothing to suggest that bad things are going to occur here. On the follow-up, 18 months later, pretty marked progression, so this is definitely one of the cases that you'd like to catch early on. One of the theories in the literature is that a pressurized false lumen is at play with disease progression here, and you'd think that there you'd have a jet in, and then maybe during diastole, a reverse jet out, speaking to that pressurization of the false lumen. So in Nick's case here, if you look carefully, at the inflow region, you can see indeed there's a sizable jet into the false lumen, and then about the same size jet reverse out during diastole. He calculated the regurgitant fraction here, which is very sizable at 90%. So it's really compelling to think that this type of focused analysis could identify this type of case for early intervention. Okay, so in summary, flow abnormalities can drive vessel wall abnormalities. And more broadly, if you look for the right flow variable, potentially you could catch disease early and intervene early. Thanks very much for your attention.